Hello, and welcome to another chapter of Pediatric Primary Care. Today we're talking about Chapter 13 Developmental Management of Adolescence. Adolescence is a period of significant growth and development, which in many ways rival the rate and degree of changes seen during infancy. It is separated into three phases: early adolescence, the ages 11 through 14, middle adolescence, 15 through 17, and lastly, late adolescence, your 18 to 21-year-olds. Throughout each phase, reassurance, information, and anticipatory guidance about what to expect are among the most valuable services a primary care provider can offer to adolescent and the family. In addition, acknowledging and respecting gender and sexual identities, as well as using correct pronouns, are crucial for developing rapport with teens. Successful adolescent development culminates in the achievement of goals that provides the basis for a healthy, productive adult life. This chapter provides an overview of development, focusing specifically on pubertal changes and sexual maturation, along with social, emotional, and cognitive changes. Common issues are then highlighted, assessment and management are emphasized, and the chapter concludes with health supervision content that is organized by adolescent phase. Collectively, this information provides primary care physicians with a framework for structuring primary care of the adolescent. So, starting off with the developmental overview of adolescence. Adolescence comes from the Latin root adolescere, meaning to grow up. This period involves psychological and physical transition from child to adult and is influenced by social, genetic, and environmental factors. Pubertal physical changes are accompanied by significant social, emotional, and cognitive shifts that affect how adolescents view themselves and how others view adolescence. Puberty is the development of secondary sexual characteristics and the biological process that ultimately leads to fertility. Pubertal changes occur on a continuum with individual differences in timing or tempo. Our understanding of pubertal timing and progression comes from studies of white participants of European heritage, research with racially and ethnically diverse children, and with sexual and gender minority young people continues to emerge. Also, of note in the recent years is the impact of early adversity, such as an adverse child experience, as it appears to predict early pubertal timing, especially for girls. This highlights another important rationale for adverse childhood experiences screening. So, speaking physical growth and development and organ maturation. Puberty is characterized by a period of rapid growth, development, and maturation. The hormonal regulatory system in the hypothalamus, pituitary, gonads, and adrenal glands undergo major changes when prepubertal and adult states. Accompanying these changes are rapid height and weight growth, secondary sex characteristic development, and fertility onset. Typical development can be difficult to define and is, at best, an approximation rather than a precise parameter. Even though the timing of adolescent development varies, the sequence of events is consistent. Sexual maturity rating. Pubertal growth and maturation assessment is completed using the sexual maturity rating scales, which are divided into 5 stages. So, the female stages. The females tend to enter puberty earlier than males. They progress sequentially in the following pattern. Starting with the ovaries, they increase in size. No visible body changes, however, occur. The larvae, or breast budding, begins as a result of estradiol secretion. It traditionally occurs between ages 8 and 13 years, with the average onset at 10.3 years. Most females, about 85%, experience breast bud development approximately 6 months before the appearance of pubic hair. The timing of breast development onset in females has no relationship to adult breast size. The rapid linear growth begins shortly after breast budding onset. Most females reach peak height velocity during SMR2 and 3 at an average age of 11 or 12 years, which is typically 6 to 12 months before menarche, or the onset of menses. The growth rate slows as females typically expect to grow no more than 2 to 3 inches after menarche. By age 15, females usually complete their linear growth. Final height is determined by the amount of bone growth at the long bone epiphysis. Growth stops when hormonal factors shut down the epiphyseal plates. The fourth stage here, the agynarchy or pubarchy. Pubic hair begins around 11.5 years and is due to adrenal development. The pubic patch, and here, initially grows in a triangular pattern that covers the vulva and mons pubis. Pubic hair is less valid than other secondary sex characteristics when assessing sexual maturation, as some females shave or wax their body hair, and there is some familial variation. To accurately assess SMR stage, the primary care provider should ask where pubic hair would be present if the patient did not shave. In addition to pubic hair, adrenal changes in puberty also lead to the development of axillary hair, acne, and adult-type body odor. And finally, menarche, or the onset of menses, occurs about 2.5 years after thelarchy. The mean age of menarche is highly dependent on ethnic, socioeconomic, and nutritional factors and ranges anywhere from age 9 to 15. It can take up to 2 years after menarche before females establish a regular ovulatory cycle. So up here is a good spot to hit pause so that you can take a look at the endocrine system at puberty, where ACTH, adrenocorticotropic hormone, PGH, pituitary growth hormone, and TSH, the thyroid stimulating hormone, will all take effect in both males and females. You also will see two graphs here that show the difference in your height. So it's the sequence of pubertal events, age and a time of physiologic change during natal female and natal male puberty, the sequence of pubertal events in the average American female, as well as the SMR, sexual maturity rating. So again, here is a good spot to hit pause. There's definitely a lot of things to take a look at to see the difference. So I know sometimes I go quickly, so it's never a bad thing to hit pause and review. We're also going to pause and review here and figure 13.3, where you see the normal female breast development, going through the SMR stages of 1 through 5. Again, SMR stands for sexual maturity rating. And lastly, here we're going to hit pause one last time to take a look at figure 13.4, the normal female genitalia development. Again, going through SMR stages 1 through 6. Female pubertal changes occur at earlier ages than in past decades, with some notable variations. An example of which is thelarchy, which occurs earlier in African American or Black females, the median age being 8.8 years, compared to the Latina 9.3 years and the Caucasian or white 9.9 years. Understanding racial and ethnic differences in pubertal timing is vital to improving health and reducing disparities. Furthermore, females who develop secondary sex characteristics earlier than their peers are at increased risk for sexual assault, sexual abuse, psychosocial issues, as well as depression. There are changes in body composition during puberty, and adolescent girls benefit from their primary care physician reassurance that these changes are typical. For example, the initial breast development usually begins as a unilateral disc-like subareolar swelling, and many adolescents and parents may initially present with concerns about breast tumors. Girls often have asymmetric breasts and need reassurance that breasts become approximately the same size within a few years after breast budding onset. Further, the female body shape changes, with broadening of the shoulders, hips, and thighs, and increases in proportion of fat to total body mass. Girls begin puberty with approximately 80% lean body weight and 20% body fat. However, by the end of puberty, lean body mass drops to about 75%, and body fat is an important mediator for the onset of menstruation and regular ovulatory cycles. An average of 17% of body fat is needed for menarche, and about 22% is needed to initiate and maintain a regular ovulatory cycle, which is particularly relevant when working with extreme athletes or individuals experiencing malnutrition. The American Academy of Pediatrics and the American Congress of Obstetricians and Gynecologists recommend that the primary care physician recognize the menstrual cycle as a vital sign because of the need for educating regular regarding normal timing and characteristics of menstruation and other pubertal signs. Acne is extremely common, and while it can affect people of all ages, adolescents and younger adults between 12 to 24 tend to be the most affected group. It usually begins during the start of puberty, affecting girls earlier than boys. Both typically outgrow acne, but about 12% of females versus the 3% of males may continue with acne into the middle age. So, before we jump into the male stages of pubertal changes that occur sequentially in males in the following order, we're going to hit a quick pause so you can see figure 13.5, where you see the normal male genitalia development and the SMR stages 1 through 5. And as always, if I'm ever going to quickly hit pause. So, the initial male pubertal sign usually is at around 11 and a half years, is testicular enlargement. Testes growth occurs approximately 6 months before pubic hair development in most males and can be assessed using an orchidometer, which is discussed in Chapter 5. Once puberty begins, the left testes generally lies lower than the right. If testicular enlargement does not precede other changes, the primary care physician needs to consider whether the adolescent might be taking exogenous anabolic steroids. The adrenarche, or pubarch, pubic hair development timing is similar to that of females. However, the distribution differs as the pubic patch tapers upward to a line of hair pointing toward the navel. Similar though to females, some males shave or wax their body hair. So again, to assess the SMR, the primary care physician should ask where the pubic hair would grow if the patient did not shave. Bringing us to spermarchy. The first release of spermatozoa generally occurs at any developmental stage from SMR3 to about 5. The first ejaculation marks the potential for reproduction, but fertility is typically reached later, about 1 year after the first ejaculation. Elongation and widening of the penis usually begins in SMR stages 3 and continues through to 5. Rapid growth and height occurs. The PHV occurs during SMR 4 through 5 and around age 14. Most males complete their linear growth by age 17, but they can continue to grow well beyond their teenage years. In general, boys generally lag 2 years behind girls and have a higher PHV than females. Change. Lowering in the male voice occurs in both males and females, but is more striking in males, coinciding with the PHV. The increase in testosterone leads to a lengthening of the larynx cartilage as it moves down in the neck. The vocal cords also thicken and enlarge. This process begins with the first sign of testicular enlargement. Finally, facial and body hair appears only after SMR4 pubic hair appears. Facial hair starts at the outer corners of the upper lip and moves inward, then appears on the upper parts of the cheeks and the middle of the lower lip, and finally grows along the sides and lower chin border. Body hair distribution is variable and is influenced by dominant trait heredity as well as ethnicity. Male body composition also begins to change. In contrast to females, males generally increase muscle mass from approximately 80% to 90% and lose body fat during puberty. Some additional changes associated with puberty may be unwelcome. Anywhere between 50 to 75% of males experience gynecomastia, which is a transient benign unilateral or bilateral enlargement of the breast tissue, generally occurring mid-puberty between SMR2 and 3, right before PHV. Gynecomastia generally regresses in 6 months but can persist for 1 to 2 years. Most cases completely resolve by late puberty. In a small percentage of males, however, some palpable breast tissues will continue to persist. Although generally benign, gynecomastia can also occur secondary to anabolic steroid or illicit drug use. As with females, acne may develop in early puberty. By mid-puberty, many males have moderate to severe acne. In cases of persistent gynecomastia and/or severe acne, the primary care physician should ask if the adolescent is using alcohol, marijuana, or anabolic steroids, all of which may exacerbate those conditions. Otherwise, conversations to have with males relate to nocturnal emission, such as wet dreams, which tend to emerge with puberty, and involuntary erections, which are ongoing but more noticeable with advancing puberty. Which brings us to the motor development. Changes in motor development plateau in adolescent females, while males continue to improve in skills requiring strength, power, and muscular endurance, which plateau later in adolescence to young adulthood. While overall motor development and abilities are attained, individual fine and gross motor skills vary widely, depending on the teen's body, interests, activity level, as well as opportunity. The tendency for motor and sports injury also varies, with female athletes having significant more knee injuries. Stress fractures are also more common among girls, with the female athlete triad, a combination of inadequate calorie nutrition intake, irregular menstrual periods, and bone loss, which will be discussed in further detail in chapters 18 and 40. Bringing us to the social, emotional, and cognitive development. Adolescents are increasingly independent and self-sufficient, often in pursuit of rewarding experiences while avoiding painful ones. However, their decision-making abilities are still forming. During the transition from childhood to adulthood, specific social, emotional, and cognitive milestones need to be assessed, as achievement helps the adolescent feel a sense of belonging in a valued group, acquire skills and master tasks that are important to the valued group. A development, a sense of self-worth, develop at least one reliable relationship with another individual, and demonstrate a cognitive potential. Bringing us to the biophysical influence. Biophysical influences. Although full sized, the adolescent brain continues to develop functional abilities along with ongoing pruning and reinforcement based on stimuli and the teen's activities and experiences. Dopaminergic and noradrenergic receptors become more active, and neurotransmitter levels increase during adolescence. There is an increase of dopamine in the prefrontal cortex and a decrease of dopamine in the accumbens, or reward center. The PFC, which coordinates executive functions of abstract thinking, reasoning, judgment, self discipline, ethical behavior, personality, behavioral modification, and emotions, experiences, and rapid growth. Emotional, social, and behavioral changes seen during adolescence are influenced by neural reactivity in the brain, particularly within the amygdala and PFC. Neuroimaging studies suggest that PFC also influences emotional regulation. Gonadal hormones also influence pubertal brain development and behavioral responses, although these neurobiologic mechanisms are not yet fully understood. The hypothalamic pituitary adrenal axis, one of the body's principal stress response systems, changes significantly during adolescence and makes the adolescent brain particularly vulnerable to stressors from adverse experiences, including abuse, maltreatment, racism, discrimination, mental illness, altered social interaction, and chronic illness. In particular, adolescents exposed to adverse experiences are at increased risk of anxiety, depression, and other mental health disorders. Other brain changes during this time may place adolescents at risk of substance abuse. Dopamine peaks in the prefrontal region and limbic system lead to enhanced neural sensitivity after reward exposure, while they have lower inhibitory control. These two factors combine to increase the potential for adolescent risk-taking behavior. Drugs and alcohol have a significant negative effect on the adolescent brain by damaging the neural circuitry in the reward or motivation pathway and shutting down the body's ability to respond to stimuli that normally generate pleasurable feelings. In essence, the drug becomes the only thing that leads to pleasurable feelings. A craving for the drug is etched into the brain, and thus the individual becomes addicted. Neuroimaging studies in adolescents with alcohol use and or abuse demonstrates decreased PFC volume, smaller temporal volume, and decreased cortical thickness. Brain changes resulting from the exposure to alcohol, especially binge drinking, can lead to loss of memory and cognitive function. Some longitudinal studies show adolescence or adolescent alcohol use is associated with a decrease in frontal gray matter and poor white matter integrity. Simultaneous changes. The central issues in adolescent development is summarized in Table 13.1. These issues cannot be understood, however, without an awareness of the simultaneous social, emotional, and cognitive changes. So, speaking specifically on the social transitions. Transition from adolescence to adulthood is continuous and generally smooth. A commonly held myth is that adolescence is a period of storm and stress. Although the characterization was not based on research, it continues to be widely believed. Adolescence is one of life's many transitionary phases, and although some teens and families experience significant challenges during these years, others pass through this critical time with relative ease. One of the most significant social changes in late adolescence is gaining the right to vote, which is an external recognition of the transition to adulthood. Changing family relationships. The biological, cognitive, and emotional changes experienced by adolescents requires reworking of family relationships. Some degree of adolescent parent adjustment or conflict is expected. However, disruptive family conflict is not the norm. Everyday issues such as clothing, hairstyles, household chores, and curfew are typical sources of conflict, and ongoing negotiations between the parent and teen are expected and essential. Inexperienced in negotiation, yet shifting to abstract thinking, adolescents can't argue a point to excess. For parents, it may help them that their teens arguing is a way of practicing abstract thinking and that they should be delighted that their teen is at least engaging with them, although it may not seem like it. When true turmoil exists, it usually represents individual and or family pathology and is not simply outgrown. Careful assessment and treatment are required. Behavior that results in negative consequences is especially worrisome. For example, fights over hair color may not be worthwhile because hair color will grow out, but delinquent or destructive behaviors must be addressed. Some emotional changes. Adolescent emotions are typically front and center, appearing more often and more intensely than those of adults. Pubertal hormonal changes contribute to this period of emotional changes, but as with the teen's physical growth and development, emotional changes can vary by individual, family norms, and sex, gender identity, and sexual orientation. Testosterone increases can be associated with sad or anxious feelings, acting out, aggressive behavior, or interest in sexual activities. Males typically develop a positive self image and mood and tend to be more satisfied with their body and body image than females. Depending on their size, they may want to gain or lose weight, which needs to be monitored, as disordered eating often begins in adolescence. Of note, male teens with adult physiques are given more leadership roles, are often more proficient or excel in sports, and are often perceived as more attractive, smarter, and more popular than their peers, and demonstrate higher self esteem in early adolescence. In contrast, late maturing boys, who are short and more childlike in appearance at 15 or older, tend to show more personal and social maladjustment over the entire course of adolescence. They can be insecure, suggestible, and vulnerable to peer pressure and are often the subject of bullying and seen as weak, immature, and less competent. Which leads us to Table 13.1, the central issues in early, middle, and late adolescence. An excellent spot to hit pause so that you can see the differences between the sexual maturity ratings, the SMR, the somatic, cognitive, and moral, self-concept identity formation, family, peers, and sexual. And the different age groups, whether it's early adolescence, middle adolescence, or late adolescence. In contrast to males, females can feel a diminished sense of attractiveness as their bodies mature and they begin menstruation. While both early maturing boys and girls demonstrate more risky behavior than those who are late maturing, girls are at greater risk as a result of romantic liaisons, and these early bloomers often get bumped up to an older group of peers and become the subject of sexual attention from older males. Of note, the body of early maturing females may not match their emotional maturity. This difference influences decision making and behavior, often placing them at increased risk for sexual activity, dating abuse, depressive symptoms, and antisocial behavior. Which leads us to the cognitive changes. Adolescents enter when Piaget referred to as formal operations, a phase characterized by using propositional thinking and abstract reasoning. The principal differences between concrete and formal operations is the emerging ability to reason using verbal manipulation. In early adolescence, thinking is still very concrete, but most teens acquire increased sophistication in abstract thought by 14 years of age. What makes things particularly volatile during adolescence is that different parts of the brain change at different times. An example is the frontal lobe, which controls executive function, is one of the last parts of the brain to fully mature. This lag can lead to lapses in judgment, an increase in risk taking behavior, as well as mood swings. As they learn to conceptualize past and future events and relate actions to consequences, adolescents begin to often question values, often challenging familiar ones, understand the concept of good and evil and variations in human nature, notice contradictions between what is said and what is done, and understanding the significance of their existence within the construct of time and what they want or will be doing in the future. While neurologic changes underlie executive function, memory, social inhibition, intelligence, and cognitive development in adolescence, emerging evidence indicates that a combination of environmental influences, such as drugs, alcohol, and stress, and genetic susceptibility can have long-term effects on the brain's structure, cognitive ability, memory, and higher executive function. Up to one-third of adolescents never achieve fully developed formal operational thinking, even as adults. So here is box 13.1, which are some tips for the parents. Again, a good spot to hit pause. Communication. As with motor development, communication abilities are mature. However, communication skills are variable and particularly challenging for parents. Understanding how our basic information needs are affected by adolescent development can be helpful, especially again for parents. Some common developmental issues for adolescents. Again, speaking on that risk taking behavior. Adolescence is a time of developing autonomy, yet many adolescents encounter situations that they are ill prepared to navigate. Risk taking behaviors continue to be a major contributor to morbidity and mortality for adolescents. Risk taking behaviors include drug, alcohol, and nicotine use, as well as risky sexual and physical actions, all of which can have significant long term health consequences. Consequently, many adolescent healthcare visits are for treatment of preventable conditions or injuries that could have been avoided, especially if a risk behavior assessment has been conducted. In the era of increased technological advances, risk-taking behaviors now include inappropriate use of social media, such as cyberbullying or sexting, and unsafe use of mobile devices, again, texting while driving. It is a paradox of adolescence that developmental tasks may be achieved, albeit in negative ways, through risk-taking behavior. Adolescents in need of peer affiliation simultaneously strive for increased autonomy while exploring, experimenting, and otherwise pushing the limit of their personal experience, often in ways that put them at risk for health compromising outcomes. It is important to recognize that risk-taking is important as teens learn to test their sense of self and limits. Understanding that risk-taking does not always equate to risky behaviors, as many adolescents engage in risk-taking behaviors without any negative outcomes. Adolescents vary tremendously in their ability to think abstractly about the consequences of their behaviors and or actions, and often rationalize by thinking, it can't happen to me, especially when it comes to emotionally charged topics, such as peer acceptance and sex. An adolescent who drinks may be doing so to feel less inhibited, be accepted by peers, and or feel a sense of independence and maturity. Because the behavior meets important developmental needs, it may be difficult for the adolescent to look at it objectively or use their advancing cognitive skills. In addition, the effect of alcohol and drugs further limit the adolescent's reasoning ability. Assessment. Environmental factors also influence adolescents' decisions to take risks, including a lack of sleep, negative or defiant behavior role models, constructive relationships, and support, poverty, or a history of or ongoing adversity. At the same time, protective factors can counter these factors and help adolescents make healthier lifestyle choices. It, it is important for adolescents to have active parental influences during these critical years, as safe, stable, and nurturing relationships buffer adversity and build resilience. Adolescents with multiple risk factors and few protective factors are more likely to engage in risky behavior. These adolescents need prompt attention and ongoing assessment. Conversely, adolescents who do well or are flourishing despite multiple risk factors should be acknowledged and applauded, calling attention to the protective factors in their lives. While the primary care physician should assess for risky behavior, equal attention should be given to the assessment of protective factors. Examples of protective factors include a high self esteem, parental engagement and family connectedness, relationships with caring adults, community engagements, a sense of future, academic success, strong executive functioning and coping skills, as well as access to recreation. All adolescents should be assessed for their level of risk-taking behavior. The primary care physician's approach to discussing sensitive issues should include ensuring confidentiality, providing privacy, using constructive communication strategies, and establishing rapport. The HEADS technique is a method of assessing risk behavior. Areas for assessment include the home, education and employment, eating, activities, drugs, sexuality, suicide, depression, and safety. Primary care physicians also need to be alert for developmental red flags because inconsistencies and delays in development may contribute to negative behavior. The following are considered risky behaviors, such as tobacco or nicotine use, substance use or abuse, which would include alcohol, poor academic performance, risky sexual activities, which would include multiple partners, unprotected sexual intercourse, drinking and driving, body dysmorphia or eating disorders, behaviors that result in injury or violence, delinquency or involvement with gangs, violence-related behavior such as carrying weapons or threatening violence, mental or psychiatric disorders, signs or symptoms of physical, mental, sexual, or emotional abuse, poor nutrition and physical inactivity, and lastly, inappropriate use of social media or technology devices. The consequence of these risky behaviors can include addiction, school failure, pregnancy, sexually transmitted infections, injury, conviction for driving under the influence, incarceration, or even death. Of note, half of all STI cases in the US occur to 15 to 24-year-olds. And here is box 13.2, which talks about that HEADS assessment related questions. So, management. Management. The primary care physician's role is to give the adolescent information and guidance to facilitate the teen making the best informed decision possible. Again, PCPs can advocate for adolescents, involve their families, communities, and school, and continue to assess whether they have at least one adult in their lives who cares for them. Consider focused interventions with an at-risk adolescent when the behavior interferes with attainment of developmental tasks or threatens their health, safety, or well-being. Adolescents who pierce their noses, shave half of their hair, and opt to spend evenings with friends rather than family may be irritating to parents. However, these behaviors are often reflections of the teens establishing their autonomy and identity, as well as learning about relationships outside of the family. Tattooing and body piercings are concerning, especially if they are associated with high-risk behaviors, and body modification should be differentiated from non-suicidal self-injury. High-risk teens. require numerous services. The primary care physician needs to know their state laws regarding adolescent health issues and decision making ability, how to access community resources, and how to engage other professionals as needed. The following here lists identify a sample of basic services that at risk teenagers may need to know, such as food resources for teen parents and their children, transportation vouchers, a temporary shelter, counseling and mental health services, foster care services for teen parents and their children, local medical and social work services, local juvenile justice systems and protective services, drug rehabilitation programs specifically designed for adolescents, alternative schools and vocational educational programs, sports, fitness, and community activities, including after school programs, and finally, community support programs. So I'm going to scroll up here so that we can take a look at table 13.3. Again, these are developmental red flags in adolescence. Here again is an outstanding spot to hit pause so you can review. Again, it'll hit up the different age groups, physical and sexual development, social emotional development, as well as cognitive development. And again, it goes through all phases of adolescence, early adolescence, middle, and late adolescence. Which now brings us to tobacco use. Tobacco use is a leading cause of preventable death, and adults who smoke often report smoking before the age of 18. Many adolescents experiment with tobacco use but may stop after a short period before becoming addicted to nicotine. However, tobacco dependence varies from one individual to another and can appear at the same time after initiating tobacco use. So, prevention and early intervention is essential. As previously discussed, the adolescent brain is particularly susceptible to the influence of substances. Again, that would include nicotine. And there is a resulting higher rate of dependence in teenagers than in adults. Despite decreases in traditional cigarette use, the rate of alternative tobacco products use, including the hookah and electronic nicotine delivery systems, such as electronic cigarettes or e-cigarettes, continue to increase. E-cigarettes are now the most commonly used tobacco product among youth, with appealing flavors and small and inconspicuous devices. The National Youth Tobacco Survey has reported 11.3% of high school students and 2.8% of middle school students currently use e-cigarette products. E-cigarettes use is highest in males and Hispanic and non-Hispanic white youth. According to the U.S. Food and Drug Administration, issued a guidance to address the increased use of ends with strategies to enforce and ban on selling ends to minors. According to the 50th anniversary Surgeon General report, over 5 million youth will experience a premature death from smoke-related illnesses. E-cigarette use is also associated with the use of alcohol, marijuana, and other risky behavior. So, assessment. An annual health supervision visit and/or sports work participation exam serves as an opportunity to screen for substance use. Both the Substance Abuse and Mental Health Service Administration and the AAP recommend that PCPs not only screen for substance use, but also the use of brief intervention and, if indicated, refer to treatment. One approach is to act. Ask about tobacco use at each visit. Counsel on smoking cessation if screen is positive, and treat by linking youth with behavioral health specialists if indicated. Ask adolescents whether they smoke or use forms of tobacco and these specific types, such as e-cigarettes and hookahs, during all visits. The management. The primary care physician's goal is to keep teens from starting use. However, in those teens who do use, the goal is cessation. The U.S. Public Health Service promotes the use of cognitive behavioral strategies, motivational interviewing, and examining the effects of social influences on smoking. Interventions need to be tailored to the adolescent's context and readiness to change. One strategy is to provide the adolescent with a quit line referral number, such as the 1 800 QUIT NOW or 1 800 44U QUIT. These telephone based interventions have been shown to help with tobacco cessation. Smoke Free is a text based service where one can quit, or I quit. Education should specifically address the avoidance of ATPs and Ns, as many adolescents view these products as safer than traditional cigarettes. Factors associated with adolescent smoking cessation include enforcing public policy that bans smoking in educational and recreational settings, enhanced self efficacy, and developing plans to manage cravings as they quit smoking. Another important tobacco exposure source is parental tobacco use. Parental tobacco use increases the risk of their child using and becoming tobacco dependent. Anticipatory guidance should address adverse effects of secondhand smoke on the adolescent's health. Evidence shows that even short messages can improve smoking cessation rates in families. Pharmacologic treatment can be offered for those with moderate to severe tobacco dependence, although with caution, as these agents are only FDA approved for the use in adults. Here is Table 13.4, Tobacco Use Cessation Strategies for Adolescents, both primary and secondary preventions. A good spot to hit pause if you're unfamiliar. Which brings us to the non-suicidal self-injurious behavior, also known as NSSI, which is a group of repetitive behaviors with the intent of causing physical harm to oneself but not with the intent of ending one's own life. Repetition is the key, as signs and symptoms must have occurred at least 5 times within the past year and be associated with at least 2 of the following: previous negative emotions, preoccupation with, and a repetitive desire to engage in activity, feeling of relief from negative emotions or a sensation of positive feelings with activity, and finally, impaired interpersonal relationships. NSSI behaviors vary widely and include cutting, scraping, hitting, burning or ripping of skin, subdermal tissue or hair, hindering wound healing, and headbanging. Piercings and tattoos are not usually included, as most are seen as socially acceptable. The most common factor among NSSI is that they are used to relieve distress, anger, stress, and other negative emotions. Research demonstrates engaging in NSSI causes decrease in negative affect and arousal and an increase in positive emotions. NSSI typically begins in mid to late adolescence and declines in early adulthood. But at least 20% of those with NSSI behavior recall they began before the age of 12. Prevalence rates vary widely across studies from 2 to 49%. However, rates potentially increased during the COVID-19 pandemic. NSSI is not suicidal behavior. However, individuals who engage in NSSI are more likely to attempt suicide or have an eating disorder, an abuse or trauma history, a mood disorder, a psychological distress than those in general population, and should be assessed for suicide risk. As many as 70% of those with a history of NSSI have had at least one prior suicide attempt. Characteristics of NSSI that are associated with increased risk of suicidality include more frequent NSSI behaviors, NSSI occurring over a longer period, multiple methods of NSSI, more severe methods used, such as burning, history of abuse, and coexisting psychiatric disorders. Although an SSI is a component of borderline personality disorder, it can be present in those without borderline personality disorder. Which brings us to its assessment. A mental health assessment is needed when adolescents present with suspected NSSI. History should focus on the type of self-injury, a description of the frequency of these behaviors, and what responses or benefits the adolescent gets by doing self-injury. Although self-injuries decrease emotional pain, they can also result in guilt. Therefore, adolescents who engage in NSSI often hide evidence of their activities, mask physical evidence, and will deny or not disclose their NSSI behaviors, thus making diagnosis difficult. Suspicion should be raised if the adolescent presents with hoodies or heavy clothing on hot days, or when there is resistance to a thorough exam. The most common location for NSSI injuries are the arms, legs, and front of the torso. There may be scratches or cuts in various stages of healing, or that appear to be in patterns or forms of words. Traction alopecia may be present. The presence of any wounds should be recognized as a call for help. Adolescents should also be assessed for suicidality because NSSI can be a predictive factor for future suicide attempts. Further, given the association of NSSI with abuse, these adolescents should be assessed for physical and emotional signs of maltreatment. So, their management. Those who self-injure will often accept help during acute phases, but lose motivation for help when symptoms are not acute. Appropriate therapeutic interventions include cognitive behavioral, dialectical behavior, and family therapy. The best therapeutic response is usually contingent on the self-injurer feeling emotions, with the goal being the developmental of positive emotional coping skills. Prompt referral to a mental health professional is needed if symptoms of psychosis or suicide ideation are present. However, not all adolescents with an SSI need a psychiatric referral. Those who are experimenting with self-injury or who engage in NSSI because of peer pressure and show no other signs of mental disorder may not require immediate intervention, but do need close follow-up. Technology and social media use. Technology can facilitate connectivity and social interaction, and social media use can be a positive influence when used appropriately. It is no surprise that adolescents spend up to 9 hours a day on different screens, and about 66% of adolescents own a smartphone and actively use at least one social media site. Although there are benefits of social media and technology devices, there are also hazards. Cyberbullying includes having negative information reported about them, having personal information made public online, being filmed without consent, and the video then being posted online and or receiving unwanted emails, messages, or texts. Peer cyber-victimization affects millions of US adolescents and increases the risk of substance abuse, depression, and suicidality. So how to assess? Parents and primary care physicians need to have an open discussion with adolescents regarding their social media use to identify risky social media usage, which would include cyberbullying and harassment, sexting, depression and social withdrawal, problematic use, and meeting or engaging with strangers through online profiles, as well as using mobile devices while driving. Its management. There's often a technology gap between adolescents who have grown up with computers, tablets, and smartphones and adults who began technology use later in life. It is common for teens to state that adults do not understand how everyone uses social media and how not being able to may have a negative social impact. Primary care physicians can remind adolescents that any post can and possibly will be shared with others, and their digital footprint can be assessed and accessed years later and negatively impact their future. Many adolescents do not realize that the possession of nude or suggestive photos can be considered child pornography, although enforcement of this varies from state to state. One rule to share with teens is not to post when they are emotionally upset, as spur of the moment actions often lead to bad outcomes in the short and long term. Furthermore, while many online profiles are real, there are also some that are completely fabrications, designed to initiate a meeting with other under false pretenses. Parents need to have frequent, open conversations with adolescents about internet and social media use. The AAP developed an online family media plan tool that helps families decide how to establish guidelines and set limits on media. In addition, parents should address the use of devices and distractions, especially the dangers of using mobile devices while driving. One study examining adolescents and motor vehicle crashes found that distractions were the contributing factor almost 60% of the time. Young drivers make up a substantial portion of those involved in a fatal car crash, and 1 in 10 were distracted at the time of the crash. Finally, primary care physicians and parents need to highlight the negative impact of media devices on sleep. Nearly one-third of adolescents wake up during the night to check their device, and screen use before sleep interferes with sleep latency as well as quality. Encourage parents to establish a central location outside of the teen's bedroom to charge and store devices overnight. Parents and primary care physicians also need to highlight the benefit of adequate sleep and negative consequences of poor sleep, and how to establish nighttime routines that promote healthy sleep, including avoiding electronic media use before bed. Health supervision and surveillance. The general guideline. Primary care visits with adolescents are grounded in good interviewing techniques, which include demonstrating respect, establishing parameters, using appropriate body language, actively listen, and communication techniques, and working with the adolescent to develop a realistic, individualized treatment plan. Each encounter needs to underscore that the primary care physician and teen are a team, and that the teen's concerns are important, that no judgment will be made, and that the primary focus is working together to achieve the healthiest outcome possible. It's important to be transparent with the teen, sharing mandated reporting and or information regarding requirements. Preserving confidentiality is essential. Adolescents should be reassured that the provider will not share information with their parent or caregiver unless the adolescent agrees, or unless the health of the child or others may be compromised. Providers must inform the teenager that there are limits to confidentiality. As mandatory reporters, primary care physicians are required by law to report information that puts the teen or others in danger. These mandates vary by the state. This proactive approach supports the adolescent while also offering protection from the parent who may be abusive or unsafe. Sharing this approach upfront with the teen and parent not only sets the stage for trust, but also reduces the problem of parents who are upset if they feel they are being denied information. Establishing trust is paramount, as teens are more likely to disclose sensitive and relevant details about their health concerns, behaviors, and risks. The way confidential care is provided may influence healthcare utilization for the rest of the patient's life. A questionnaire or checklist may be an effective way to collect information for teenagers who are hesitant to discuss sensitive issues. Questionnaires used to identify adolescent strengths were created by the Search Institute and have been used by communities to enhance adolescent self concepts, whereas programs like the Rapid Assessment for Adolescent Preventative Services helps primary care physicians identify risky adolescent behaviors. So, assessment and screening. In the physical development, adolescents should have height, weight, body mass, index, and growth trajectory documented at each health maintenance visit. The SMR should be recorded to evaluate progression of pubertal changes. Assess testicular growth by palpation and sizing using the standardized orchidometer. Self-assessment is generally reliable, and adolescent males can be asked to evaluate their own developmental level if provided with standards against which to compare themselves. Varicocele or enlarged veins palpable in the scrotum may develop at sexual maturity and are not cause for alarm unless a discrepancy in testicular size is noted on exam. Gynecomastia in boys should be noted, especially beyond SMR3. Scoliosis may develop rapidly during puberty, and assessment should be done annually with careful attention to SMR and PHV. An example is a female with mild scoliosis. SMR4 and who had menses 2 years ago is less cause for concern than a female with mild scoliosis. SMR2 who has not had menarche, as this teen may need close monitoring throughout the growth spurt. Each teen should be asked how they feel about their own physical growth and development. Dissatisfaction with body appearance might warrant further probing to elicit unhealthy behavior. The thyroid gland should be palpated, with special attention to the presence of the Delphian node, as autoimmune thyroid disorders may occur during this age group. Social and emotional development. Key areas to assess is social and emotional development, including adolescence emerging independence from family, relationships with peers, and social and goals for the future, especially as they enter late adolescence. Adolescents need to be interviewed about school, family, and peer relationships, exposure to violence, abuse, or weapons, mental health issues such as mood, depression, anger problems, or suicidal ideation, sexuality, sexual activity, and sexual orientation, safety, and involvement in risky behaviors such as tobacco, alcohol, prescription or street drug use, as well as eating disorders. The cognitive development. Cognitive assessment includes the following questions about school attendance, school performance, and education or career goals. School connectedness is a significant predictor of adolescent well-being. However, the extent to which a teen connects to school depends on characteristics of both the teen and the school. A teen's exposure to a school-based health center is also associated with school connectedness. School connectedness was an important factor with remote learning during COVID-19 pandemic, as students with more connections to others at school had lower rates of poor mental health outcomes, such as hopelessness and suicidality. Chronic absenteeism, class skipping, and other types of school avoidance indicate a problem that may be related to cognitive ability and should be assessed in depth. Objective assessment of cognitive development, as with school-aged children, requires formal psychological testing, which is best done, if needed, through schools. Children who are behind a grade have a much greater risk of dropping out of school, thus leading to consider school failure as a form of adolescent failure to thrive. Parent assessment. Parents of teens need advice, support, and encouragement. Characteristic adolescent mood swings constrain family relationships and lead to arguments. Parents with balanced approaches that include unconditional love, clear boundaries, and consistent discipline are more likely to have adolescents with less depression, less risk-taking, and better academic success than authoritarian parents. It's important to assess parental concerns about their adolescent health at each visit. because their concerns provide additional insight into the teen's physical, socio-emotional, and mental health, as well as a glimpse into the family functioning and parent-teen dynamic. If problems exist in the parent's view, or there is a discrepancy between the parent and the teen, or a potential conflict emerges in the interview, the primary care physician can facilitate mediation and or intervention as needed. Some anticipatory guidance. Anticipatory guidance should be individualized to help the adolescent understand, respond to, and take responsibility for their own behavior and development. Separate discussions need to be conducted with parents to help them understand and support their teen's maturation and need for independence. In these discussions, the primary care physician should clarify which values and expectations parents have for their teen and how the teen perceives those expectations. So here we're going to hit pause so you can take a look at the adolescent areas of development and the related anticipatory guidance, whether it is physical, cognitive, or social/emotional. So a good spot to hit pause. In the following sections, specific discussion points are outlined in each of the adolescent phases. While they can be incorporated into the health supervision visit, they are not all inclusive, and they often cannot be covered exhaustively at each visit. Ideas for assessment and management of specific problems that emerge from the discussions can be found in other chapters. So, starting at early adolescence. Early adolescence. Early adolescence is often the most difficult adolescent adjustment period. Rapid physical changes occur simultaneously, with changes in all parts of the adolescent's life. Yet their cognitive skills may not keep pace with physical changes, and their emotions may interfere with or overwhelm their ability to understand and cope. The early adolescent is often confused and even frightened by the rate and breadth of change being experienced. Accordingly, they can be difficult to be around, yet, because of this difficulty, the response from parents and other adults may be exactly the opposite of the support, caring, and understanding they desperately need. Their physical development. The onset and rate of physical changes in early adolescence varies widely, with some teens exiting early adolescence still at SMR2, while others are at SMR4 and almost their adult height. Close attention to the onset and sequence of changes is a priority for the primary care physician, while simultaneously monitoring the teen's response to the changes. Social and emotional development. The early adolescent is beginning to renegotiate relationships with parents, other significant adults, and peers. While they may not yet be a part of an adolescent subculture, they can appear to be anti-adult and often find themselves in between the two, feeling lonely. They begin to prefer friends over family and often report their parents to be an embarrassment. This social behavior pattern is a step towards maturity and independence, as one of the ways of demonstrating independence is to challenge parental authority. Parents may report the early adolescent as more argumentative and disobedient, refusing to do chores and wanting to renegotiate rules. Wide mood swings are characteristically present in the early adolescent. They may shift from euphoria to sadness within a matter of minutes, characterized by their transient nature, commonly measured in hours or days. These emotional fluctuations need to be distinguished from the unremitting, long-standing mood and behavior changes of serious depressive disorders. Further, as they adjust to the physical changes of puberty, they may begin to spend more time in front of the mirror, combing their hair, checking their skin, and putting on makeup. Clothes and appearance become more important for most teens, including those with a developmental delay or disability. The onset of secondary sex characteristics typically increases anxieties about menstruation, nocturnal emissions, uncontrolled erections, masturbation, and breast or penis size. This is an opportune time for the primary care physician to dispel myths, such as masturbation causes blindness or acne, and provide focused anticipatory guidance. For example, a premenarchal girl often has vaginal leukorrhea, a clear mucoid discharge. However, they may find these conversations awkward at first. These discussions can be challenging, as early adolescents have a desire for greater privacy, often spending more time in their room alone, listening to music, using social media, texting, or talking on the phone. They may magnify the problems and believe that no one could possibly understand what they are feeling. The development of new types of friendships appears as a greater number of opportunities to become possible. Same sex friendships occur, usually with one best friend. These strong friendships may lead to fleeting same sex experimentation as sexual feelings emerge and adolescents develop their sexual identity. Contact with the opposite sex is usually in groups. Other typical sexual behavior of the early adolescent include masturbating, telling dirty jokes, making lewd remarks to others, demonstrating interest in watching explicit sexual scenes in the media, or looking at images of nude individuals. Sexual experimentation may vary greatly depending on the adolescent's subculture and development. For example, by this age, some teenagers have already experienced sexual intercourse or pregnancy, whereas others may not have even held hands. Cognitive development. As their thinking abilities develop, teens daydream frequently. Parents and teachers need to be reminded that daydreaming is needed cognitive work for adolescents. It is where they work on their and through their identities, as well as the changes in and around them. Early adolescents begin developing their own value system, independent from their families of origin. They may try value systems other than the one that they learned from their families, often leaving family members befuddled or even threatened. As they develop, give early adolescents the opportunity to use their growing reasoning skills to actively problem solve, explore values, and examine the principles on which they make decisions. Early adolescents set idealistic goals that change frequently. One day they want to be an engineer, and the next day a pilot, or a parent who stays home to raise children. Some adolescents at this age experience a drop or rise in academic performance depending on their current focus. Health supervision and screening. Annual health supervision visits are recommended. Critical components of the visit include growth and developmental surveillance, assessing social and academic progress, including quality of interpersonal relationships, and school performance, identifying emotional wellness and risk reduction, including injury prevention, substance use prevention, and healthy sexuality. Immunizations for HPV or human papilloma virus, diphtheria and tetanus toxoids, and a cellular pertussive vaccine. Influenza, hepatitis A, and meningococcal meningitis are all recommended. Blood pressure monitoring should continue and serum lipoprotein analysis should be done if not done earlier in childhood. Anticipatory guidance for the early adolescent focuses on explaining the rapid changes that are occurring, helping the adolescent in the early process of developing self-concept, autonomy, and independence, and providing reassurance that they are normal. The following should be specifically discussed. Physical changes to expect as puberty progresses. How adolescent can be best managed, the rapid physical changes. Nutritional needs. Increased iron and calcium intake is needed for menarche and during periods of rapid growth. Coping strategies the teen and family can use during the stressful times and building resilience where needed. what it means to be sexually responsible, both physically and emotionally, which can include abstinence counseling or safe sex practice and education. And finally, the transition to adult healthcare. Initiate conversations regarding transitioning to adult healthcare between 12 and 14 years of age, especially with teens with special healthcare needs. By age 14 to 15, a transition plan should be developed with the adolescent and parent. Which brings us to that middle adolescence. Those 15 to 17-year-olds. Middle adolescence is characterized by continued changes in physical, cognitive, and socio emotional development. Relationships continue to evolve. Peers become increasingly influential, and awareness of one's and others' appearance is accentuated. With increasing cognitive abilities, middle adolescence often provides opportunities to evaluate and develop the skills necessary for adulthood. However, it is also the time when teens are at highest risk for developing mental health disorders, and sexual and risky behavior experimentations begin. So, some of the physical development. For most teens, especially females, physical development nears completion. Middle adolescents typically have less concerns about body changes as they have been dealing with them, but have increased interest in making themselves more attractive, which can be relative. Teens spend more time with hair, clothes, and for some, diet and focused physical activities, such as weightlifting. Middle adolescents often try to defy the limits of their bodies, and many have periods of excessive physical activity followed by periods of lethargy. Some social and emotional development. School and extracurricular activities outside the family are often the focus of the middle adolescent's life. Peer groups involvement is intense and includes the establishment of a dress code, communication style, and code of conduct. Middle adolescents tend to be more non adult than anti adult. The need for peer contact is important for all middle adolescents. However, it is especially important for teens with developmental disabilities and or chronic conditions, although it can be challenging. Sexual drive emerges, with physical urges often preceding emotional maturity. While most begin to explore their ability to attract a partner of the opposite gender, same gender, or gender and sexual minority partner, there is often increased peer pressure to experiment with sex. Adolescents report that parents are the main influence of the adolescent's decision about sexual behavior, something parents need to be reminded of, especially as a parent/teen conflict peaks over the issues such as curfew, allowance, going to parties or movies, and dating. For both the teen and the parent, rules and expectations must be clear and consistent. Cognitive development. Intellectual sophistication and creativity increase in middle adolescence. Practicing reasoning, logic, and decision making strengthens the adolescent's ability to establish healthy evaluative and decision making skills. They may demonstrate increased concerns with neighborhood and societal issues, which would include racism, poverty, justice, peace, and the environment. Health supervision and screening. Annual health supervision visits are recommended, including annual influenza immunizations, growth and developmental surveillance, and assessment of social and academic progress, quality of interpersonal relationships, school performance, and emotional wellness. Screening for STIs is needed if the adolescent is sexually active. Paminiculo or pap smears are no longer recommended until after the age of 21, regardless of sexual activity. Tuberculosis screening is often needed as teens enter the workforce, but also if risk factors are identified. If a lipid panel was not completed earlier, or if risk factors emerge, it should be completed. Some PCPs order a screening CBC for females after menses begin, although clinical practice guidelines do not support this practice. Anticipatory guidance, therefore. Anticipatory guidance for the middle adolescent focuses on the teen's expanding physical, cognitive, and socio-emotional capabilities, consolidating self-concept and identifying areas for continued growth and development. The provider should acknowledge and reinforce healthy behaviors and validate the adolescent's physical, intellectual, and social development. Specifically discuss physical changes that allow for increasing skills, recommend regular, vigorous physical activity, fitness, and engagement in a wide range of activities. Risks and dangers related to drug, nicotine, performance enhancing drugs, caffeine, diet, pills, and alcohol use and abuse. Injury prevention, risky behaviors, involvement in extracurricular activities, relationships between nutrition, health, and a positive body image, healthy sleep habits, importance of completing high school and making plans for the future, sex and sexuality, the responsible, safe sexual behaviors, prevention of STIs, birth control, including emergency methods, preventing and reporting date rape or intimate partner violence, sexual orientation, breast or testicular exams, existence and nature of peer relationships are based on mutual respect and caring, gang involvement or bullying, nature of relationship with parents and caregivers, are reasonable limits set, do parents show interest and concern for the teenager, emotional maturity, how does the adolescent resolve conflicts, manage anger and or frustration, or reduce stress, mental health assessments, potential for self-harm. If a plan for a transition to the adult healthcare is not already in place, one needs to be developed. These plans must be based on an assessment of the adolescent's ability to provide self-care and the needs and desires of the teen and the family. Once in place, plans should be re-evaluated annually. Adolescents with developmental or intellectual disabilities require additional support to foster the adolescent's ability to participate to the fullest extent possible in their medical decision making. Which brings us to the late adolescent, the 18 to 21-year-old. Late adolescence is a time of behavioral autonomy. It is when most adolescents have a clearer self-concept. Life choices are made, and decisions about how they plan to contribute to society as a responsible adult are implemented. Physical development, physical growth and development are typically complete, although some teens, mostly males, will continue to gain height into their early 20s, as PHV occurs later in males. Social and emotional development. Relationship with parents and family are gradually renegotiated during this phase to a more adult-to-adult pattern of communication and collaborative decision making, even when they disagree. The role of the parent during late adolescence should be one of support as their adolescence evolves towards young adulthood and re engages with the family. Young adults often develop a modified value system, which is very similar to the one with which they grew up with. A substantial number of late adolescents have established their sexuality and entered into an intimate, committed partner relationship, including marriage. Partner selection is based more on individual preferences and less on the peer group's values. Much of the final identity shaping centers on the late adolescent's perceptions of their future options as adults. Individuals affected by violence and other traumatic events can experience prolonged stress that jeopardizes their developing identity. As of July 2021, 54% of teens and young adults ages 16 to 24 years were employed, 61% enrolled in college and university, and 33 were working and enrolled in college. For those who are able to choose to attend college, it can offer a moratorium or a prolonged adolescence, a time to further clarify one's self-image, as it offers both maximal autonomy and a structured, supportive environment in which to complete developmental tasks. Those who enter the workforce or leave home out of high school do not always have the added time and or supportive structures of the college experience. Adolescents who are unsuccessful in the education system or in the workplace may opt to establish their identity by joining gangs or becoming socially isolated. Some opt to join the military, which provides an alternative structured environment but may lead to them taking on adult responsibilities for which they may not be psychologically or emotionally be prepared for. Cognitive development. Late adolescents have adult reasoning capabilities and skills, but are still gaining experience with both. They are generally capable of understanding the consequences of their actions and behaviors and make complex and sophisticated judgments about human relationships. They no longer base their judgments about people on overt behavior and have a good understanding of inner motivations, including multiple determinants of an action. Of course, neither teens nor adults consistently use this mature level of thinking, and some never reach this level of cognitive maturity. Health supervision and screening. Annual health supervision visits are recommended, including an annual influenza immunization. Screening for STIs is needed if the adolescent is sexually active, and pap smears should begin for females at age 21 years, regardless of sexual activity. Tuberculosis screening is indicated if risk factors are identified. A fasting lipoprotein analysis is recommended at least once during late adolescence. A plan for transition to adult care should be clearly developed by this time. Transitions involve providing medical records and referring the adolescent to an adult primary care physician. Many teens benefit from the pre transfer visit with an adult provider. PCPs can also assist the adolescent to learn about health insurance, how to use the healthcare system, and to take responsibility for self care, especially as they may be removed as dependents on their parents' policy. Which leads us to our last section here, the anticipatory guidance. Anticipatory guidance for the late adolescent centers on the transition from being a teen to taking on the responsibility and role of an adult, which includes how physical activity, exercise, nutrition, sleep, and rest are incorporated into the lifestyle and budget. Strategies to balance responsibilities of school, family, and employment. Conflict resolution and stress management strategies. Future goals and plans. Ways to clarify values and beliefs, identifying talents and interests to be pursued, and taking on challenges that increase self confidence. Need for and maintaining relationships with family, parents, siblings, friends, significant others, and community. Injury prevention strategies, and sex and sexuality. Again, the responsible sexual behaviors, including safe sex, continued exploration and clarification of sexual orientation, management of sexual feelings, STI prevention, date rape and intimate partner abuse prevention and reporting, birth control, including emergency methods, childbearing and child rearing considerations, and finally, breast or testicular self examination. There are some additional resources available, which would include the Adolescent Health Transition Project, Alliance of Professional Tattooists, the American Academy of Family Physicians, the American Academy of Pediatrics, the AAP Adolescent Healthcare Campaign Toolkit, as well as the Family Media Plan, the CDC, Family Acceptance Project, Ginsberg, a parental guide for building a resilience in children and teens. Got Transitions, resources for health providers, Menstrupedia, the National Runway Safeline, Parenting Teens and Tweens, Rapid Assessment for Adolescent Preventative Services, Rape, Abuse, and Incest National Network, SACS, and the Society for Adolescent Health and Medicine. Which concludes our chapter here today. We'll review some of the references as always, but that should conclude our chapter here today. As always, I thank you for listening, and I'll see you at the next chapter. Till then, take care and goodbye.